Welcome to the Charleston CFO Council. This organization was co-founded in 2015 by Robert Bendetti and Mark Carmichael in order to provide a networking and educational forum for senior financial executives to share best practices, to discuss current financial issues, and to learn about current topics related to the performance of their job.
To kind of kick this off, Isla was born June 4th, a friend of mine's granddaughter, born on the same day as my oldest son, June 4th. And Isla, we're going to project that she's going to graduate from Clemson in the year 2040. She's going to enter the workforce as a marketing analyst. She'll, of course, get married, have a child, get a house, and move to Raleigh, North Carolina. I've kind of got her life mapped out here. But bear with me and take a look at this, give you a snapshot 30 years from now, if things continue to trend the way they are today. Average salary for two earners, $132. In 30 years, it'll be $243. A PPO family contribution is currently $737. In 30 years, that would be $33.45. 16% of her salary. House prices would more than double, and total percentage of salary for benefits and a mortgage would be 37%. This would not make Dave Ramsey very happy. So are we losing the American dream? If things continue the way they are, maybe. But there's things that we all can do within our organization to make sure that doesn't happen. So before I get into the actual data, I want to share with you what the data is made up of. We've got two benchmarks that we're going to look at today. One is the Southeast area. It is made up of 215 companies, $773 million in healthcare, and roughly 64,000 employees. So these are average around 300-400 employees for this group. So this is a mid-market study. The national benchmark, these have over 22,000 companies and 1.7 million employees. So this is going to give a great representation of benefit data across the country. You can see in 2019, we've got several states now that we're getting over 500 surveys from. South Carolina, we got between 251 and 500, but every state is now accounted for. Even the great state of Alaska, we have gotten, Alaska and Hawaii, we have gotten benefit surveys from. I'll jump into the data at this point. So plan prevalence, this is the type of plans that are in place in the Southeast. The PPO plans, which are a copay plan, if you've got copays in the plan, it's typically a PPO. That's 59% of companies have that. High deductible plans are now at 36%. That number continues to grow. In the Southeast, it's very rare that you'll see a HMO, POS, or an indemnity plan. HMOs are very big in California. The number of plans offered. This may validate some of your thinking when you're looking at your own plans and how many plans you're offering to your employees. 52% of companies only offer one plan. 32% of companies offer two plans. And then that's the most. That's the majority of companies. 84% offer two or less plans. You have a small percentage that offer three plans, and 7% of companies offer four or more. I'm going to take a quick pause and see if we've got any questions, Robert. Robert, you're muted.
Oh, I muted myself. Oh.
Gotcha.
Oh my God. Yeah, but my son will edit this out, so you'll never see it again. Question number one is, why don't companies offer all the plans?
Well, that's a good question. In offering four or more plans, the reason why some few companies do that is it can get very complicated for employees. I think healthcare in general is complicated, but when you give an employee multiple choices, 4, 5, 6 different plan options, they get very confused of which plan to choose, and they're always second guessing themselves. So keeping it simple is important, but then also administratively trying to keep up with that many plans is brutal on an HR department.
Another question was just around definitions, Matt. I got different, I'm going to combine some things, but on the previous slide, you used PPO, high deductible. I'm not as familiar with the EPO. Could you just define some of that stuff?
So EPO, HMO, that is where back in the 80s, it was more popular here, where you have a gatekeeper. So you have to have a primary care physician, and that primary care physician is the gateway to any other specialist or referral. And then some EPOs are in-network only, so it's very narrow network, and you have to go to this particular healthcare system, and out-of-network is no coverage.
Okay. And I'm going to hold the rest of the questions until the next break.
Okay. Let me go back. All right, so on the so now we're getting into the actual copay plan. So what we're looking at here, we've got, Robert, can you see my mouse on the screen, or is that not possible?
Yeah, I can see it.
Okay, so on the national median, this is the black bar, so you'll see this on all the graphs going forward. We've got data from back to 2016 nationally. The blue bars, this is going to be, the top bar is the 75th percentile in the Southeast. The middle bar, the darker green, is the median, the 50 percentile. So this is kind of the right in the middle benchmark. And then this is the bottom line is the 25th percentile, the best of the best companies show this benchmark. So this is the deductible. In a copay plan, the national benchmark is right around $1,200. Notice the Southeast, the median is $2,000. So the Southeast has less rich benefits on average, but the top companies, the top 25% companies have a deductible on copay plans of $1,150. So it's an interesting dynamic when you look at national versus Southeast. On the coinsurance, the coinsurance has been static for a number of years. Coinsurance is the amount of money employees pay after they reach their deductible. So they're going to pay their deductible, and then they go into a coinsurance level where they're going to pay 20% of their benefits up to their out-of-pocket maximum. So this is fairly standard to be at 20%, but we are seeing companies start moving that up to a 30% coinsurance, putting more risk for the employees. They're having to pay 30% instead of 20%. But this has not changed too much over the years. This is an important number, out-of-pocket max. So notice nationally, it has not changed. This stayed steady at $4,000 nationally, and we predict it's going to stay that way. But on the Southeast, for PPO plans, the median is up to $5,000. So this is a 50 percentile. So out-of-pocket maximum, this means the worst case scenario for employees. With the ACA, there's a maximum amount that an employee can pay in a year for claims. And so if they're a high utilizer that has multiple surgeries, there's a lot going on, they would cap out at this number. I want you to remember the 4,000. I'm going to come back to this when we talk about a high deductible plan. But these out-of-pocket maximums, we are projecting them in the Southeast to continue to climb slightly as companies are looking to try to reduce cost. Office visit copays have been very steady at $25. We see some companies in the 75th percentile start bumping that up to $30. Nationally, in the median has been $25 for a number of years. So kind of a summary on this PPO copay plan. This is a snapshot of the Southeast and national. What I'll bring your attention to is the specialist copay down here at $50. That's the benchmark nationally as well as Southeast. And then these pharmacy copays, you may want to pay attention to these. This is typically it's a 4-tier where the $10 generic copay, the $35 brand preferred copay, $60 brand non-preferred copay, and then a specialty pharmacy at $125. So this is something you can check your benefit plan to see how they compare to this benchmark. I'll pause here, Robert, and see if there's some more questions.
And I unmuted myself this time. There are some questions. Question number one is either why is the Southeast does not provide as rich of a deductible or have higher out-of-pocket expenses, or what parts of the country are much more generous? Maybe they are distorting the national data and creating that variance.
Yes, great point. And if you look at anywhere that has a union, so union shops in the Northeast, unions typically drive extremely rich benefits. So there's a lot of areas in the North that would have higher benefits. And any companies that we work with that have unions have extremely rich benefits for their employees.
Are you seeing any trends in, and I've got 3 parts to this one, and how it might impact plan design or cost? The first one is on-site clinics or near-site clinics.
Yeah, so that the direct primary care on-site clinics, we are seeing a bump in those. The near-site clinics there's been a lot of, it has worked in some situations. I think the biggest thing with near-site clinics is having the utilization high enough to pay for the cost. You have a lot of employees that don't want to leave their doctor and don't want to leave their primary care that they've had for a number of years. So the near-site clinics in some situations don't get the utilization they need to pay for themselves. So you've got to make sure that the near-site clinic is something that's close enough, that it's not a 30-minute drive for employees, and that they are willing to use that near-site clinic and not their primary care physician that they've been using for a number of years. On-site clinics have been fantastic. Increased productivity. Employees can go to an on-site clinic, get taken care of what they need, potentially prescribe medication, and be back on the work floor without having to miss half a day of work. So typically you need at least 500 employees to have an on-site clinic. That has been very, very good.
Same question, but with a different angle is, how about virtual care? How do you see virtual care impacting plan design? And do you see virtual care continuing, growing? Seems like there's been some changes in state and federal law to allow more, at least during COVID. So virtual care, what are your thoughts?
Yes, so we've got a slide on virtual care. It's going to be, the next generation is going to be all over telemedicine. COVID has forced healthcare professionals to get in that game. So a lot of your own primary care physicians, you can now do a video conference with or telephone. So it is going to grow, and it is going to be a cost saver for doctors, for members, for everyone. So it's going to make people a lot more productive. I see that being a huge increase this year. It's already been a huge increase this year and next year as well.
Are you seeing any more emphasis from employers on communicating?
Right. Robert, could you repeat that? Could you repeat that, Robert?
Yeah, sorry about that. Can you hear me now?
Yes.
It is, are you seeing any trends in employers communicating lower cost sites, lower how for employees to be consumers of healthcare?
Yes. So there's some new things out for sure. Health Joy is one that comes to mind, and there are a few others that are having employee advocates that are trying to steer employees to a high quality, low cost provider. And that is something I think is going to be in the future for sure, where employees are going to think of it like a travel agent, where employees would use a health travel agent to help them decide, instead of going on vacation, where they can go to have surgery, where they can go to get an MRI done, to be the most effective, high quality, low cost place. Because there's huge difference in pricing, going to a hospital facility to get an MRI versus going to an imaging facility. And those navigators, I think, are going to be a big deal going forward.
Yeah, Matt, I'll just echo that. There's a tool, there's probably a million of them, but with our carrier where you can do a search in your area for the services that you're looking for to give a comparison, and it is astonishing the price difference. It's like 10x, unbelievable price difference. Couple more questions, and then I'll hold them. One question is, this is a macro question. Why do you feel that healthcare is still tied to employment versus maybe a trade group or all employees just being able to go get it in an open market? Why are we still tying health insurance to employment, Matt? And do you see any changes in the future?
Well, I hope not, because Robert, you may have to hire me with my accounting degree, so I don't want to lose a job. But I think some of the, when I've spoken with employers about potentially disbanding their benefits, it asks me the question, why are you even offering benefits? Because everybody can now go on the individual marketplace and get insurance themselves. So we have that. But the 9 times out of 10, it's the employee. They don't feel like the employees are going to be able to navigate that. And it's just a huge benefit to have it taken care of. An employee gets hired, and my benefit comes with my job. And it's easy. I can do open enrollment. I have my information. I just feel comfortable doing it through my employer. But I mean, you could disband it today and have everybody go to the exchange. ACA penalties out there, but I think it's a matter of convenience, at ease, a recruiting tool for employers.
Matt, last question for this pause is around plan design and network design. Any recourse when an insurer kicks a large medical provider out of network?
When an insurance provider repeat that question, make sure I understand it.
Yeah. When an insurer kicks a large medical provider out of network.
Yeah, so that does come up. These contracts renew. So when an insurer kicks out a large network, there's disruption, and you've got employees that have been going to this healthcare system for years and years, and all of a sudden they're out of network. So there's typically just major disruption. Members are angry. CEOs are angry. And it's up to the health systems and the insurer to get together to get their contracts aligned and bring everything back in network. So I think the insurers are trying to lower cost and get the best cost they can. And health systems are trying to stay afloat and be competitive as well. So there's a lot of disruption when that happens.
Matt, I'm going to hold the rest of the questions to the next stop.
All right, let me hit high deductible. High deductible plans, these have no copays. So this has been trending upwards. A lot more companies are doing this now than they were 10 years ago. Nationally, the high deductible median continues to grow. It's at $3,000 now. The top 25% of Southeast companies have kept a fairly low deductible at $2,000 for their high deductible plans. So this means the employee would they don't have any copays. Every time they go to the doctor, they're paying the full cost, the full discounted rate, until they pay $2,000. The 75th percentile has their deductible at $4,000. Coinsurance, at top 25% of companies have a zero coinsurance down here, which means once they pay their deductible, that's their maximum out of pocket, they're paid in full. Nationally, it used to be up at 20%. It's down to 0% in 2020. Typically, well, a lot of times though, we still see the median and the 75th percentile up at a 20% coinsurance. So this means that once an employee pays their deductible, then they would pay 20% of that bill until they hit their out-of-pocket maximum. And remember, I told you to remember the $4,000 out-of-pocket maximum in the copay plan. This is something that we see quite often with companies. High deductible out-of-pocket maximums are sometimes lower than the copay plan. So in this particular situation, the high deductible plans, the top 25% have a maximum out-of-pocket of $3,500. The top 75% have $6,500 as their out-of-pocket max. But if you've got a high deductible plan and the out-of-pocket max is lower than your PPO plan, that means a high utilizer that has a lot of medication or surgeries or a lot of things going on, they would be actually better off in a high deductible plan because their out-of-pocket maximum is lower. So if you've got an employee that knows they're going to have high costs and they're a user, a lot of times they choose the PPO plan because they love the copays and they think that is the best insurance out there. But financially, they would be paying less if their out-of-pocket maximum would be lower in the high deductible. So an interesting piece to look at as you're identifying your benefits. On the high deductibles, one thing to note here is the employer contribution to HSAs and HRA. HSA is a health savings account. HRA is a health reimbursement account. So this is typically something the employers fund with high deductible plans. The Southeast benchmark is that the employer will give an employee $600 a year, and they would give family $1,000 a year. Nationally, the benchmark is $750 for employee only and $1,200 for family. We are seeing a lot more HSAs today than we have been in the past, much more HSAs than HRAs. I'll pause there and grab another question or two, Robert.
First question is, Matt, you seeing any market or demographic or employer trends that are either raising costs or reducing costs in the next 5 years? Anything for us to keep an eye out for?
Well, yeah, absolutely. Some of the recent studies that we've looked at on the employee supply chain and starting running numbers on how that can actually help if we get all employees going online and being a consumer, and the numbers are significant. We just had some presentations here of the past 30 days that we're going to be implementing in 2021. That the employee supply chain, when you get an employee that's engaged and get them shopping for their health care like they shop for a new car, it is going to be significant how that changes an employer's cost. So I think that is one huge item that's going to be out there. And then I think you're going to see continue to see partnerships with these high deductible plans and employers funding employees, giving them seed money and allowing them through high deductible plans to be better consumers. We 9 times out of 10 we'll see better experience, better cost when we get companies in a high deductible plan with this seed money than we do a copay plan that doesn't have any transparency and it's just copays nonstop. Healthcare travel agents is going to be a big deal in the next few years.
Any specific recommendations around employee consumerism and best practices maybe in communication or education with employees? You seen anybody do it really well?
Yeah, well, it can't be during open enrollment, and that's it. It's got the best consistently educate employees and are transparent with employees about how their contribution and their due diligence not only helps them out, but also helps the company out. So communication that's throughout the year is the best. You can't do it one time and expect the employees to have it down pat. So consistency is very big, and then you just got to let the employees know that they don't have to go where their doctor refers them to. I mean, we get in the healthcare system and just the doctor refers and they just go get an MRI somewhere. But people have a choice, and you can go where you want to go. So you've got to have a partner. Hopefully the broker that you guys are working with can get a plan together where there's, whether it's lunch and learns, videos, grabbing employees and doing annual throughout the year type of training.
Personal share is my wife got food poisoning. We had to go to the hospital, and I'm convinced the doctor just wanted to cover his butt and just started like recommending every possible test you've ever heard of. Including a pregnancy test. And for reasons I won't disclose, that'd be like a triple miracle for us to have another kid, like direct involvement by Jesus Christ himself. And the doctor was astonished that I was like, hey, how about we skip that test? Because that's not cheap at a hospital, if you're wondering.
That's right. You've got to take ownership, and you've got to ask a lot of questions. You can't go buying healthcare. You've got to treat it like anything else that you're purchasing that costs a lot of money.
Matt, one question we got is around how does employee mental health and wellness play into this? We mentioned communication or training or tools. How's that play in all this conversation?
Oh yeah. So the EAPs have just exploded. With you used to get a free EAP with the disability carrier. They would kind of throw it in. It has 3 visits. What we've seen an explosion of is the EAP that companies are wanting more, 6, 12 face-to-face visits for employees. It is a necessity for employees to have an outlet. I've got 2 teenagers, so I had to seek a therapist myself. So I am a believer of that, and it's extremely important. The mental wellness with COVID, the stress. Watching the news stresses me out. I can't even watch the news at night anymore. I get too anxious. So EAPs and mental health is a huge item.
Okay, I've got a bunch of other questions. I'm going to hold for time, and then I'm going to hit you up at the next spot.
Okay. We're going to keep growing here. So I'm going to hit you with dental. Give you an idea, dental is the second most expensive benefit that you guys offer. So just making sure it is tight. The $50 deductible on dental is pretty much standard across the board. The 25th, 50th, and 75th percentile, nationally, Southeast, $50 deductibles are norm. Here's a quick breakdown on Southeast dental. You can see it mirrors up. These have been very consistent for the last 10 years. They haven't changed. The annual maximum for dental is around $1,000 in the Southeast, and then at $1,500 for the national. So a little bit difference there. And then ortho max typically is at $1,000 and $1,500 nationally too. So very consistent on the dental. All right, so how are we doing? Everybody hanging in there? Get a cup of coffee? We'll keep powering through here. The final cost increase. So 2020. So think back to what your renewals have been this past year. Going into 2020, the national median for cost increase was 5%. This is after plan design changes, but nationally 5% was the median. The 75th percentile had increases at 9%. The median in the Southeast was 4%. And then the best of the best Best of the best companies had a flat renewal for 2020. So interesting numbers here on the medical for 2020. Comparison of total premium. So this is where, from a CFO standpoint, this is where the rubber meets the road. You've got comparison of total premium for employee only. So the top number is total premium. That's the 609. The employee portion is 130. And this is for a PPO plan, okay? So the employees on average are spending 130 a month. The employer is subsidizing 479. So you can see percentage-wise, it's close 75, 80% that the employer is subsidizing, leaving the employee with this 130. And nationally, it's a little bit more where the employee is spending 168. Their cost is 587. And then on the high deductible plans, you can see the employees are typically spending 86 a month. And nationally, they're spending 119. And the totals are above. So the high deductible plans, notice that you're subsidizing a lot more on the high deductible plans, trying to incentivize those employees to choose high deductible over the PPO. So it's an interesting concept where this may be closer to that 80% plus mark, where over here it's more like 75, 80%. If we look at the family comparison, total number again is at the top. This blue is the Southeast for PPO. And the two to the right, the blue is the Southeast for the high deductible plan. Notice, the thing to notice here, we've seen this shift, is that the employees, notice how much they're paying percentage-wise. I mean, it's close to like 40%. So on the family, what we've seen the trend, and here are the benchmarks that prove it, employers are subsidizing much less on the family tier than they are at employee only. So you got the total numbers, and then it's an interesting dynamic how that has shifted. And a lot of companies are now doing the carve out for spouses, where they're saying if your spouse is working at another company and is offered benefits, then they're no longer allowed on your plan. So if they can get it at another employer, they're disqualified and they're no longer allowed to get benefits here. So it's another mechanism to try to provide good, healthy, strong benefits for the employees, and maybe not so much for the spouses or family as we had in years past. I'll stop there and grab another question or two, Robert.
Yeah, Matt, will you flip back to the previous slide?
Sure.
I'm going to ask these questions out of order and receive just because this one's timely. So if I look at this slide, I think what I'm seeing is that if I'm an average Southeast PPO or HDHP, my costs are higher, but in every previous slide, my benefits were lower than average. So what's up with living in the Southeast? It seems like a lose-lose. You get worse benefits and my costs are higher.
Yeah. So have you, Robert, have you ever deep fried any food?
Hey, you don't need to be getting personal, sir.
Yeah. So that is a good point. So when you look at these numbers, I mean, some of it is health related. If you look at obesity, we do have an unhealthy population in the South. There's no doubt about that. So nationally as well, I mean, when the Southeast is so condensed. Like if I looked at New York is about 20% higher than South Carolina. California, same way, is about 20% higher. But some of the smaller rural areas in the Midwest bring the national accounts down. So there are definitely pockets that are much more expensive than we are. But overall, when you look at the national piece, the Southeast does have, if you look at our obesity rates, the Southeast has pretty bad numbers when you look at that. And the obesity does have much higher costs that go with it.
You mentioned the spousal coverage and surcharges. You seeing anything with dependents or children? Is that Is that something you have flexibility in a plan?
No, we have never seen any carve outs with children. So no. Now children could potentially qualify for Medicaid. So it's some of the, to have education to give employees outlets if there's, depending on the situations, the brokers having the ability to educate employers with all the different ways people can get covered through, Medicare, do Medicare training, make sure 65 know how to get Medicare, Medicaid for those individuals that could qualify. That may be something they want to take advantage of for their children. But nothing from a carve out where you would blanket everyone and say, hey, children, we don't typically see that at all.
You ever seeing any expanded definition of a dependent with blended families, or maybe older family members coming to live in the house? That's a question for me. I don't know how that works.
Yeah, absolutely. So in fully insured, you're more dictated by the contract of the carrier. But if you're self-funded, I mean, you do have flexibility of blended families and who you want to cover. I mean, children are going to be kicked out at 26. But I mean, with stepchildren and different things like that, you can definitely make adjustments for eligibility if you're a self-funded plan. But it can't be, for the executives that get one rule and then all the employees get another rule. It would have to be for all. Once you make that eligibility definition, that would be across the board for everyone. So it would be probably a huge risk if you expanded your dependent definition too broadly.
I'm going to hit you with some rapid fire ones for time. Question number 1 is, you talked about the national and Southeast rate increases, averages. What part of that is COVID related? Either keeping it flat or increasing it? What's COVID? How's that coming into play?
Robert, I'm sorry, repeat that one more time.
How's COVID impacting the annual rate increases you had on a previous slide?
Yeah, I'll cover that next slide. I'll get to it in just a minute.
We talked about consumerism. What about in educating our employees? What are we seeing on how are we educating doctors' offices so that they even understand their own pricing? So our employees can call them and ask, well, how much does something cost? I've experienced that myself, where the doctor's office has absolutely no idea how much something costs that they're recommending.
So in 2021, there is going to be healthcare transparency that the government has kind of forced down, that people are going to have to start showing pricing and coming up with that price list. So I think those bells have been going for a long time now. And in 2021, you're going to start seeing much more price transparency, where they're going to have to divulge that information. And it's going to be membership pushing these doctors, asking the questions and forcing them to give you the answer. But I think 2021, you're going to see a big shift in that transparency coming out.
I'm going to hold the questions for time and mute myself.
Okay. So COVID, the question you just mentioned, so Milliman projects the COVID pandemic could reduce 2020 healthcare expenditures by $75 billion to $575 billion. So depending on when vaccines come, we've just seen a huge decline in claims where people, either got their elective surgeries postponed, just weren't going to the doctor. So what we've seen is a big decrease. That really the second quarter of 2020, almost all clients have seen this, where the claims just went downhill big time. So there's a lot of different models depending on vaccines, and what's going to happen is when this is going to pop back up. But we've definitely seen a decrease. If you ask the question, in the past 3 months, have you or a family member in your household skipped or postponed any type of medical care because of Corona? You're going to get a 48% that say yes. So of that 48% that say yes, well, did your symptoms get any worse? 36% said no, 11% said yes, my condition did get worse. So what these three slides are saying is basically healthcare costs have gone down due to COVID. People are not going to the doctor, and that 11% that are not going to the doctor, that their condition got worse, there's speculation and worry from insurers that this is going to come back and be more severe in 2021. So a lot are hedging their bets, trying to figure out, because no one's going to the doctor right now, is 2021 going to have a rebound that's worse than it was if COVID was not here? So, no one has a crystal ball on it, but that is the concern from a carrier. Is they're going to get a rebound with big claims in 2021? But there's no doubt I would be surprised if anyone on the phone, I mean, it could happen, but I would say the majority of folks have seen much less claim activity second, third quarter of 2020. Oh, sorry, I went backwards. Let me keep, I want to go through a couple slides here. This may be important to someone on the phone. On the self-insured benchmarks, the slides on the left here, these rows are employee count. So you're looking at breaks in employee count for employers. And then the blue, the percentages are who's self-insured and who's fully insured. So if a company that's less than 50 employees, almost all of those, 95%, are fully insured. But check out at 50 employees plus, the numbers, how they change completely. The 50%, 50 employees to 200, 32% are now self-funded. 200 to 500, majority of those companies, 59% are now self-insured. 500 to 1,000, 77%, and almost all of 1,000 plus companies are now self-insured. Almost 90% of 1,000 plus companies are self-insured. And the reason why is if you take a hypothetical group of 353 employees and you've got 4 tiers, you've got employee only, that costs $503, employee plus spouse costs $1,000, employee plus children costs $940, and family costs $1,708. If I do the numbers and make that a composite, total is $848 per employee per month, the cost for 353 employees. If I look at a fully insured rate, that $848 is broken down into these 7 detailed items that you may not even be aware of, but fully insured rates are broken down by medical, cost, pharmacy, and then all these other things at the bottom. The self-insured side of it, if you take the same medical cost and put it over here with the same pharmacy cost, you have much less claims administration. Your broker fee's still there. You got some ACA fees, but not all in a self-funded environment. And you still buy some protection because you can't be completely eliminated from insurance. So you still need some stop loss protection. But typically you can get much less fixed costs in a self-insured program. So you could save potentially in this example, $237. If you were running well and had low claims, aggressively, if you had lower claims, you could potentially save $500,000. And then conversely, the devil's point of view, the conservative route, if you've got high medical claims, it could end up being more expensive than fully insured. So this is the risk you run. 1 year out of 5, you're probably going to have a bad year, but 4 out of 5, you're probably going to run as expected or a little bit better. And the 4 out of 5 years could be a win. So this is the reason a lot of those companies are now looking at self-insured to be able to get more detail, transparency, and take more risk and reap the savings. I'll stop there and see if we got time for a couple more questions. All right, Robert, I'll keep going.
We do have a couple questions. I was just reading them, sorry.
Okay.
I'll pull one of them. On this slide, one of the big price differences seems to be the ACA insurer fee. And that seems to be like a tax arbitrage between these two examples. Is it going to stay that big of a difference forever? Any chance in self-insureds having to pay a higher ACA insurer fee at some point?
Yeah, I think politically, we'll see what happens, but this is a Congress. What they keep and do away with will be a total political item. But we thought it was going away, and now it's back. So I don't foresee that going away.
And is there something in the middle for smaller companies where they can join a group of people that we're thinking about, or I like this word, they use the word coalition.
Coalition.
Yeah. Options for smaller companies if they want to look at self-insured?
Yes, there are different groups. Some associations have started to put some things together. So if you're in a trade, an industry that may have a benefit, like the Bankers Association, they pull all the banks together in a self-funded environment. So some industries are starting to do that, so you can check that out. A PEO is good for a 25, 30 employee company. There are PEOs out there that will pool companies together and can do some good things and benefits. And they're also, for some smaller companies, a captive environment that may be a good alternative to self-funding. So there are definitely some different options out there, and it just depends on what the industry you're in and the risk tolerance you have. There are level funded products out there. So just, work with your broker to get all the options, because you should definitely have more than a fully insured option put in front of you to make a decision on.
Hey, Matt, I'm going to let you close up here. We got a couple minutes.
All right. I'll close up with a couple quick ones. Benefits, if you look at some innovative things, free parking. So big cities, Charlotte, maybe downtown Greenville, parking is a benefit. Not for me and my company. Our parking is pretty free already. But that is something in the bigger cities. It's a big deal. Cell phones are a great benefit, providing those. 30 seconds on tuition reimbursement. If you have a population that is young, that has student debt, part of your benefit program could very well be that we as a company are going to pay your tuition. We're going to pay X amount per year. We're going to pay, $200 a month toward your tuition to get your debt paid off. And you can couple that with them working for you for a 4 or 5 year period. And if they don't, it's a clawback. So tuition reimbursement, young population, you have a lot of student debt. Put this in your benefit plan. It could be a huge recruiting tool and retention tool to use going forward. Last slide, telemedicine is at 51%. Next year, if I'm doing this again, this number will probably be at 70%. Casual dress, fifth of the companies are doing that. Sit-to-stand workstations. That's becoming a big deal. I've actually seen treadmills in companies now where they're putting a stand treadmill desk. And they've got to be, they're walking while they're checking email. Snacks provided, and now identity theft is another benefit that's being put out with all the cyber threat. And this is a nice kind of voluntary benefit. Identity theft protection, because it can cripple someone financially. And there's so many threats out there. We see huge Fortune 100 companies getting hammered every month. So that may be something you want to talk about, offering identity theft to the employees. So Isla, how good is she going to be? Well, we'll have to see. But hopefully 2050 won't be as bad as the benchmarks predict. Robert, I appreciate your time. I know you want to wrap up. It's 8:56. So if anyone has questions, feel free to reach out to me directly on the benchmark data. I'd love to talk with you and answer any questions that you may have.
Awesome job, Matt, and well done finishing right on time. And I think what we got here is a great tool. And I'm going to share the deck. I'm going to send it out to all members. And then also a copy of the recording. I think this would be a great tool to maybe sit down with human resources to benchmark our plans. It's great timing because we're all just about either in the middle of renewal or about to start renewal. So great timing, Matt, and great information. I think also I put a big exclamation mark around the comment that education can't just be during open enrollment. And I definitely have fallen in that trap where either I or the HR team member, they're talking about consumerism and tools and new resources that are available, but they're doing it once a year. And that isn't frequent enough. So that was excellent. I put a highlight, an exclamation mark around that. And folks, if you're thinking, wow, my broker doesn't share information like this with me, I don't have resources like this, you might also, in addition, have a quiet conversation with HR. Matt's around. You want to have a quiet conversation with Matt, bounce your plan off against these benchmarks. Matt might be the perfect person to sit down with and go over that. Folks, I'm going to post something on LinkedIn about this event, and your job is to like, comment, and share. All three of those things. We bring this great content to you because somebody out there in the market saw and heard about the Global CFO Council, and they usually hear about it from LinkedIn. So all you got to do is move your little finger and like, comment, and share. If you want to say something like Robert was awesome or Robert's super handsome, that is completely allowed. Folks, thank you very much. Everybody have a great day, and I give you 1 minute back of your life. Thank you, Matt.